Testing 1 2 3. Testing 3 2 1. Testing 1 2 3. Testing 3 2 1. Testing 5 4 3 2 1. Testing 1 2 3 4 5.
1, you're live.
Good morning, everyone. Thank you for being here. The Finance Committee of the Tarrant County Hospital District will come to order. It's a 10:01 on February 25th, so thank you all. Mr. Mendenhall, any citizens wishing to address the committee this morning?
No, sir.
See the way that Mr. Mendenhall said, sir, Mr. Early? Do you like that?
I will bring that up in his annual evaluation. It'll be a part of that.
I think that's bonus material there. All right. Well, thank you, Mr. Mendenhall. We'll move on to item 3, which is approval of the minutes from the January 28th Finance Committee meeting. And I will entertain a motion on that item.
This is Zim, move to approve.
Motion by Mr. Zimmerman. I hear a second.
This is Dorothy. I'll second.
Second by Mr. Bose. Any discussion, any changes? All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you very much. We'll move on to item.
I thought you did a great job on that, sir.
See, that's what I like. Thank you, Mr. Powell. We'll move on to item 4, CFO report. Ms. Clark.
Hi, good morning. The one thing that I wanted to point out this morning, on your board portal, in the last few days, we posted both the Moody's credit release or the press release and the credit report. If you recall, S&P last month was able to reaffirm our rating there, and I'm very excited to announce to you that with Moody's we actually got a revised outlook, and it went from negative to positive, or just stable, not positive. So it was one notch up with that upgrade rating. So currently we are at a AA3 stable outlook. You know, it's an annual process that is really interesting for me. We get a chance to give a presentation. It was virtual, but we're able to develop a rapport with those groups from Moody's and S&P, and that's important as we start to communicate our plans over the next 5 to 10 years. Of course, they're very interested in a multitude of factors. So they look at the economy in Tarrant County, they look at the management team, they look at our past performance, and there's all kinds of things that go in there. But I do believe that that report is really important with that team. So that was my one big win for this month.
And that's a really big win. Despite our finance chairman, we got an upgrade. And I want to applaud Sharon on that, because that doesn't happen by itself. It's articulating how we're doing, pointing out how we're managing our resources. And so I applaud her, and I applaud this board for your work on this. That doesn't happen on its own. So thank you.
Well, thank you. It was a good day, to say the least. If you want, we can roll on into the financial report. Let's see, let's go to the next 2 pages on the graphs. You know, I've got to say that January, we are 4 months into 2021, and these months look very consistent. I will point out some interesting things that happened in January, but we have been again, the first quarter performance and this month, first month of the second quarter performance are very in sync. We did have admissions that were below budget, but if you can see at the blue line on the graph at the top left, that's pretty consistent through January. What made this month a little bit more interesting is our case mix index at the bottom of the page and the length of stay. So you can see that we had one of the highest CMIs that we've had recently, and that's reflected by the increased length of stay for this month. So even though it looks like our admissions were down, our patients stayed longer, they were sicker, and our patient days were almost on budget. So when you look at the resources that are consumed, you know, the admissions are down, but everything else has remained fairly constant from an inpatient standpoint.
Hey, Sharon, this is Trent. Was that a COVID-related variable?
There's a couple of things that is going on with case mix index. Revenue cycle has really started to educate on documentation, so we're able to record a more accurate CMI. The COVID patients are much sicker, and we have quite a bit of uptick in the CMI for those. And then we've seen an overall decrease in admissions. So those that are not as sick are not admitted. So there's kind of a different mix of acute patients. So we have fewer patients, but they're very acute. Next page, please. Our ED and our urgent care, again, under budget, but very consistent with prior months. And on our clinic visits, our primary care was down a little bit this month, and our specialty care was actually over. From a percentage standpoint, the striped portion of that visit line is telehealth visits. Primary care, we ran about 63%, and specialty clinic visits, we had telehealth on about 44% of those visits. Next page. Probably the more interesting trend is at the bottom of the page with surgeries. Our inpatient surgeries, we were right on budget this month for those. But back in December, when we saw an increased COVID rate, we had to suspend some of our outpatient surgeries that were performed in Arlington. That continued through January. It was not just the COVID uptick, but we also brought staffing and equipment back to deal with some of those issues. So you can see our outpatient surgery has dipped. Next page, please. From a mental health standpoint, again, very consistent on days. Our emergency visits continue to be over budget slightly. And the outside medical services, those that come in through the emergency area that require admissions, because of COVID and social distancing, we have struggled with making sure that people get into an appropriate environment and an inpatient. So we have utilized some of our partners outside to accommodate the social distancing, but also the increase in the emergency visits. When you look at the clinic visits at the top right of the page, we have about 44% that we continue to see and use telehealth. So you can see that we've kind of moved to a more normalized telehealth utilization in 21.
Hey, Sharon, this is Trent again, and I appreciate you breaking out telehealth on psych. How do we illustrate telehealth on non-psych visits, and how does that mesh in with our overall primary care clinic visits? Is that
so? If I can get to move back 2 slides on the presentation. So here's the clinic visits. The primary care is at the top right and specialties at the bottom. Again, those percentages they vary slightly each month, but you can see the majority of our primary care, about little over 60% is telehealth. And then specialty care is about 44% telehealth. So in some months, it's about a third.
We're not seeing a big spike then in telehealth visits as a result of COVID or anything else?
No, you can see in January, we did move from a trend standpoint, a few more to telehealth. You know, patients, as they start to hear on the news, the upticks tend to convert over to telehealth, or from a clinic standpoint, we may try to manage more telehealth than in person if that works. But we did see a slight increase from a percentage. Those, the stripe part of the bar is a little bit more in January than it was in the first quarter. But that may normalize in February.
Yeah. Okay. It's an interesting statistic to watch because as we consider how we move forward on the bond program and what dollars need to go to primary care clinics relative to telehealth seems to be a good metric to follow.
Well, and this trend is still skewed by a lot of things. I don't know that we're seeing a normalized telehealth usage yet. In February, I assume that number is going to be pretty skewed because of the ice and the issues that we had with the storms. And I know that Joy Parker and her team was aggressively trying to reschedule visits, in-person visits, and convert those over to telehealth. So there's a lot of issues that may impact February as well.
Good, thank you.
But it is interesting, on average, a third to a half can be done virtually.
Yeah.
If we can go back about 3 pages back to the days cash on hand right there. It's January is always a fun month. We get our first payment from the ad valorem taxes. So you see that spike. It's kind of a natural trend. We'll also get some of those in February for those that wait until the last minute to pay those taxes. And then you'll see the natural downward trend. Just as a reminder, we're at about 350 days cash on hand, and about 50 of those are related to COVID relief funds that we still have on the balance sheet and may have to repay at some point in the future. We're still working through those calculations. Our FTEs per adjusted patient day are slightly unfavorable year to date at the bottom right of the screen, and you'll see that our salary dollars are pretty much on track from a dollar standpoint on the next slide. A couple of slides back. Next slide, please. Here's our connection enrollment. We're actually kind of seeing a leveling off. Typically in January, we see a big change where the ACA plans are coming on, and we see that kind of decline in January. But what we've been doing since March is allowing an auto renewal to occur for these connection patients. And now we're starting to reevaluate as their original month has come up. So once they've been on the connections for a year, we're beginning our normal process to reevaluate and get those people re-enrolled. So we kind of leveled off in January, which was quite unusual because there's usually a bigger decline. Next slide, please. The next slide. So from an income statement standpoint, can we move to the next slide? We had another favorable month. You can see that operating revenue was actually positive, even though we had a lower volume in a lot of areas. We were able to make up with a slightly favorable payer mix. Also impacting that net patient revenue, again, which is the dollars we expect to collect from the services that we provided in January. We did not budget for some COVID payments to continue, but those are getting extended 90 days at a time. So the HRSA payments that allow a payment to be made for self-pay COVID patients is still coming through. And Medicare is also continuing to pay an additional amount for a COVID positive patient. That equates to about $1 million a month. And again, we don't know how long those emergency relief payments will continue, but those are real dollars for us on a monthly basis. We also had that really high CMI increase. And A lot of our payers, including Medicare, that is a multiple of a base rate. So as we see those high CMIs come through, you're going to have a lot more cash that comes in the door.
And
The other
Sharon,
thing,
Sharon,
yes.
let me interrupt real quick because I know many of you all as board members are sensitive as well as our community. The assistance from the federal government is greatly appreciated, but these are uncommon times, and the price that we have to pay, the additional staffing, the taking people out of one unit and putting them at the bedside for COVID patients, those are not pluses necessarily for us. Those are helping us afford the challenges of COVID. And I know that many of you all as board members and in our community as well is that cynicism that COVID is a boon, and it's not a boon. It has been a constant struggle to deal with staffing issues and the challenges, particularly in nursing, when other units in other industry, other health networks will pay exceptionally more to have a traveling nurse. And you have the challenge of having nurses leave because they can make more if they travel and go to different places. So it is a real challenge. We are thankful for what we are receiving from the federal government, but it also allows us to continue to maintain the healthcare we're providing.
Thank you, Robert. And again, you know, we're not getting just extra payment. It is based on COVID positive patients. And when you start to look at the expenses, you can see that that supply number is over budget as well, at 13.4 million compared to 12.9 million. Most of that is related to our inpatient drug costs, and a lot of the treatments that the COVID positive patients are receiving are extremely pricey. So, you know, we're having increased expenses with these COVID positive patients. Because of some other expense savings that we had, it was a positive month, as I mentioned before, at 14.4 million. And then the year-to-date number is at 53 million. You know, I try to educate people whenever I have an opportunity of, wow, that seems to be, you know, quite a bit of money. There's a lot of things that we're doing with these excess funds, which may not last in the future years, trying to build up our cash pool so we do not have to incur as much debt as we enter into this master facilities plan. If I can help reduce that 800 million debt burden that will occur over the next 8 or 10 years, that's the goal. So some of these excess funds that fall to the bottom line, that's how we increase that cash pool. We also have expenses that we're having to deal with today for capital that those dollars get used for as well. So just as part of the planning, and back in my intro talking about our credit rating, and us being able to achieve some comfort level with these rating agencies, that we are operating in a financially sound way and our operations are supporting long-term goals, and keeping all of those things in mind, I think is really going to help us with this next phase as we go into talking about issuance of debt and what burden that will place on this organization going forward.
Wait, Sharon, and maybe Steve, this is a question for you. Knowing that when someone looks at our financials and they see these numbers and they compare them, say, to a Baylor or another, you know, charitable, our numbers are much higher than everyone's. And I'm always a little nervous about the optics of that, because it doesn't, as Sharon said, it doesn't really tell the whole story. I wonder, especially in light of the bond program and the capital debt program going forward, is there a way to characterize what we're terming or what we're illustrating as excess funds in a manner that would really illustrate where those funds are probably going to be dedicated and earmarked, so it doesn't look like there's just this big, huge, massive chunk of cash out there. Because the deduction that people honestly make is, well, then you should lower your taxes, or well, you're just not seeing enough people, or there ought to be more people on connection. I mean, there's 10,000 different, deductions that can be made from that perception. And I'm wondering, from a formatting standpoint and looking at our overall numbers, if there's not a way to potentially earmark or at least footnote some of these funds relative to that obligation.
Tran, I will say, the board has been diligent with the creation of the JPS Future Fund, and those funds are kind of a statement to a lot of external people of this is our commitment and this is our savings account for the bond program and the master facility plan. But that lives on the balance sheet. There's not, at least from an accounting standpoint, to pull it off of net income. We can footnote that at the bottom, and we can continue to remind people that, we've got about $150 million in the future fund right now.
I think it's a good footnote, Sharon, only because it shows that we're able to continue contributing toward what will be a reduction in our debt ratio in the future. And I'm not sure how to do it. I know we can't do it from a GASB standpoint or a GAAP standpoint within the cash flow sheets, but I wonder if there's just not some way to format it so it's clear where this is going, because I get that from time to time. People are like, oh my gosh, JPS makes more money than anybody. I'm like, well, don't look at it that way. That's really not the way that it's really pans out.
And again, I don't want to make the mistake of us just looking at this income statement. Although it is positive when we look at the consolidated income statement in a moment, it's a much lower number as we think about those physician investments that we're making.
Yeah.
And, that's really where I think we've got to do that comparison. Also, we have some unbudgeted items that we are addressing, in the first quarter. And I'm going to try to bring a summary back to the Finance Committee. Steve and I have talked about it, of some items that we know are coming up, whether it is kind of a emergency for plant and facilities, or whether we're working on strategy, whether we are working with Broadus and that group as we start to plan. We've got some really big items that are not in this budget, and they're also not in the actual. So I think some of these overages will start to help facilitate some of that planning as well.
Good. Well,
before the end of the year.
However you want to depict it, I think it's healthy to do that, because we all know those obligations are out there, and as a function of normal hospital debt, JPS is still minuscule, and it does paint the wrong picture of perception sometimes.
Yep, I agree.
I agree.
Great. Good comment.
Yeah, thank you for bringing that out. And my team will play with that for, let me brainstorm on that for a bit, and we'll bring something back next month.
Thank you, ma'am.
Agree with Trent.
Can we skip forward about 3 slides to the graphs for a claim? Thank you. A claim was also impacted by some of those closures that were happening. So they're just slightly down this month, only by about 4% for build encounters. And then if you look down at the bottom left, the denominator, because it's slightly lower, did negatively impact the net operating expense per encounter. However, year to date, we are about 4% favorable on that metric. Let's go 2 slides forward to the income statement for a claim. Again, their volumes were slightly under. You can see that on the top side of the income statement. And they were right on budget for total operating expenses. So a claim ended the month at about 4.9 million. Year to date, they're at 13.2 and favorable by 3.6 million. If we can skip to the next page, which is our consolidated income statement. Just looking at the year to date on the right hand side, when you add these three together, kind of in the bottom third of the page, our income from operations is right at $40.5 million. Again, it's favorable by about 17 million, and I'm going to be bringing some information back to you guys where I'm kind of looking forward throughout 2021 and trying to project where we may be towards the end of the year. That is all of my prepared remarks for this morning.
Any questions for Sharon on this? Okay, hearing none, I think I'd be in order for us to consider acceptance of this report of the January unaudited financial report from Ms. Clark. I'll entertain a motion to that end.
Move for approval. CT.
Motion by Mr. Nguyen.
I'll second it, Steve.
Second by Dr. Weber. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, everyone. Sharon, if we'll move on to item 5B, please.
For the next few months, I'm going to be bringing back policies and procedures to you as we go through and do a thorough update of some of the finance policies that have been out there for more than a decade. So today I'm asking for approval of policy 4500, which is our annual operating and capital expenditure budgets policy. No major changes to this policy or procedure. We really just tried to document what we were doing today and how that flowed, and using some up-to-date terms. So if you looked at the red line, there's really no substantive change to this policy.
Any questions for Sharon on this item? Hearing none, we'll be open to a motion on this. Item B.
This is Dorothy. Move approval.
Motion by Mr. Bose.
Second. DT.
Second by Mr. Nguyen. Any further discussion? All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, everyone.
Thank you.
Item C. Thank you, Sharon. Dr. Elliott, item C.
Hello, good morning, everyone. Good to see you.
Good morning to you. Good to see you as well.
Thanks.
Good to be seen.
Thank you. So we are here presenting to you one of our medical education affiliation agreements, and for approval for our ophthalmology agreement that is between University of Texas Southwestern Medical Center and the Tarrant County Hospital District. We've had this agreement in place. Now it's time for renewing that agreement and moving forward again. This would be a little over $500,000 annually and over a 3-year term, over $1.5 million. And this supports all of our faculty in terms of the teaching and supervisory roles for our ophthalmology residents that come through here. It's been a very positive thing, not only for our educational mission and academic mission and research, but also for our patient care. So I'm seeking your approval for this MEAA.
Okay, you've heard Dr. Elliott's explanation. Any questions for her?
Mr. Trent, move
Mr. Chairman, I move for approval.
Second.
Wow, you guys are easy today. We have a motion and a second. Motion by Mr. Powell, second by Mr. Petty. All in favor of the motion, please say aye.
Aye. This doesn't refer to the chairman, but I thought the presentation by Dr. Elliott was excellent.
Thank you so much. Appreciate that.
Thank you, Ms.
All the best.
Thanks for the commentary, Mr. Powell. All in favor of the motion, please say aye. Wait, we already did that, right? All opposed? Motion passes. Thank you, Tricia. Appreciate it. All right, item D. Ms. Prachel. Diana, how are you?
Good morning. Thank you.
Good morning.
I come before you with a release agreement with Sheridan, who is our current anesthesia provider. Their contract will expire and there is a non-renewal of that PSA effective May 31st. This agreement will allow those providers who currently work for Sheridan to be released to pursue employment with the new provider that will be starting in June without violating their restrictive covenants. The one-time fee would not exceed the $1.4 million. That would be based on if everyone stayed, which is not likely. Some will stay. It will also keep from interruption of their credentialing and privileging at JPS. So that we have a smooth transition on June 1st. The board will see the new contract coming forward for the new group next month.
Okay. This is an interesting one, and it took me a little while to get my head around it, but it is actually a pretty reasonable thing to do. We're essentially buying out the non-competes, correct, for these providers, so that we can keep them, keep the continuity of service. And ultimately, it's a pretty financially wise move to do. Is that correct?
That is correct. Yes, we did receive a discount in the buyout from the individual providers' contracts. It has been contemplated in the budgeted transition cost for moving to a new group this summer.
So, Diane, does this, and Steve, what happens if we don't see the full panel of physicians change to the new group? Is there a potential that we end up with short panels because we don't have the same number of physicians available to treat?
The new group is a large organization, and it's their responsibility to fill that coverage requirement. And they will do that with their internal locums group as they hire up. But they are already anticipating the move, and we're not anticipating a problem in coverage.
Okay, thanks.
Any other questions for Dan?
I just have a minor question. I think Sheridan was bought by Envision.
They are.
Are they still keeping that name, or?
Our contract, Sheridan was bought by Envision, and so it is Sheridan / Envision, but the previous master service agreement was with Sheridan as a part of the Envision group.
So they still operate under that name?
They're still operating under Envision. That's correct.
Any other questions? Okay, I entertain a motion on item D.
This is Zim, move to approve.
Second.
Motion by Mr. Zimmerman, a second by Mr. Nguyen. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you. Item E is pulled from the agenda. It actually does not require board approval. So it's already been transacted, so we don't need to consider that. We're pulling it from the agenda. Item F, Mr. Lane.
Hello, everyone. Can you hear me?
Yes, we can.
Sir.
All right. Thank you, Mr. Chairman. Great to see all of you again. For some reason, my webcam is not working right now. I come before you today to present an addendum to our Southwest Elevator contract. It is to provide maintenance services to ensure that we maintain our monthly preventive maintenance on all our elevators, all 52 elevators. 320,000 of that is for the remainder of this year, which is unbudgeted in the current budget. And the remainder over 3 years is $1.52 million. This agreement terminates with the base contract as well. It does have a 90-day out as with the base contract.
So Adam, if you could clarify for me, this is they were providing the services to these all these elevators currently, but we're not being paid for it. Is that what I understood from the summary?
That is correct. JPS focused them primarily on the elevator modernizations. If you recall, they modernized purple elevators the previous year. They're doing the red elevators this year, and the Finance Committee approved $990,000 in capital for that this year. This memorializes their labor that they've been providing and adds additional so that we are in regulatory compliance with monthly elevator preventive maintenance.
Okay. And I know that this predates your arrival at JPS, but this is unbudgeted, but obviously this will be part of future budgets. We'll know about this going forward, right?
Yes, sir.
This Dorothy, I want to clarify something, Steve, because I thought when we went with this contract, we did get them to replace, but are you telling me that that contract didn't have any maintenance on all the elevators with all the problems we had with our elevators?
It did, but it had annual maintenance, and the requirements are for monthly maintenance, and they've been providing service for us to do that at no charge.
Okay, well, I guess I'm surprised it was annual since we were already having so many problems with our elevators at that time, but I'm okay.
Yes, ma'am.
Okay.
Dorothy, one of the things that may help you is going back and looking at this. When we had the elevator challenges, we looked at total refurbishing of those elevators. And we put our emphasis on, as Adam said, taking out all the purple elevators and all the red elevators. So we put a yearly contract on maintenance. And regulatory wise, that should be a monthly maintenance agreement. And so there's a little bit of vernacular here about yearly to monthly, but none of the elevators went without service. We're just changing over to a monthly process from a billing standpoint. And I don't mean to take that lightly, but I think when the contract was made with Southwest Elevators, it was to immediately begin and refurbish the elevators that were so outdated.
Yeah, I remember that, but I also thought that we were very conscious that we had elevators going down all the time, and we didn't want that to continue. So okay.
We did. And so we set it up on a yearly basis, and Southwest Elevators has been fixing those elevators on a monthly basis. We're just trying to pay them properly instead of on a yearly basis, but on a monthly basis.
Okay, so now you'll have 2 people in-house to make sure for the maintenance.
Yes, ma'am.
Okay, all right.
Okay. Any other questions for Adam? Okay. Any entertaining motion on item F?
Move for approval.
Second.
Motion by Mr. Wynn. I'm sorry, I didn't catch the second.
Zimmerman.
Second by Mr. Zimmerman. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, everyone.
Thank you.
I'm sorry?
Said thank you, everyone.
Thanks, Adam.
Thank you, Adam. Appreciate you. Item G, Mr. Chung, how are you, Doug?
Good. How are you guys?
We are good. Thank you.
Awesome. Well, I'm here before you today to ask for approval of an agreement between ARUP Laboratories and Tarrant County Hospital District. Total cost on an annual basis is approximately $4.5 million, or a little over $22.7 million over a 5-year period. The 3-year initial term does have 2 additional years that can be renewed as both parties agree. Really, ARUP has been a partner of the lab for many years now, and really they provide the ability for the lab to send out appropriate testing that is to a centralized point, and thus allowing us to provide a more cost-effective test menu for our patients and for the hospital. This contract does hold a 90-day out clause with written notice at any time. And once we receive a greater than 80% send outs to a single source, or ARUP in this case, that will save the district approximately $450,000 a year, or $2.25 million over the life of this contract. We currently, send out about 90 to 95% of our tests in this contract with ARUP. So I don't see any issues with receiving that discount.
Okay.
Steve, can you tell me, I probably should know this, but I don't. Is this the contract that we pay to do all of the COVID test lab work, or does that come under the main JPS lab category? I'm trying to figure out where that additional activity and cost is housed.
So this contract is really for kind of some, not for COVID. We contract with a couple of other different entities for COVID testing specifically, and then obviously we run our own in-house testing ourselves. This contract is mainly around some labs that we run on a very infrequent basis, but we still would like to provide that service to our patients, obviously. And so we outsource those labs, and we're constantly evaluating kind of what we are outsourcing to ARUP to be able to say, does it make sense financially for us to make capital investments to bring that in-house, right? And so that's an ongoing process in partnership with ARUP. They actually provide a tool that we use on a month-to-month and year-over-year basis to do that analysis. And that's an ongoing iterative process with myself and lab leadership.
Okay, thank you, Doug.
Thank you, Doug. Any other questions for Doug on this? Okay, hearing none, we'll entertain a motion on item G.
Recommend approval, Steve.
Second.
We have a motion by Dr. Weber, second by Mr. Petty. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, Doug. We'll move on to item H. Ms. Dent.
Good morning to the board. I have 2 purchase agreements to present with approval for cranial and oral facial products. These are products that we use for our neurosurgery, dental, and our trauma cases. These are drills and supplies that allow us to drill into craniums and into our facial areas. The first one is with Stryker. Stryker is a current vendor. This is a 3-year initial term with a 1-year renewal agreement. We will save $117,489 per vendor. These are the first 2 of 4 vendors that I will present that will be able to supply us with this need for our trauma program.
Okay, any questions for Ms. Dent on item H?
Question. Is this for all 4 of them? It's going to be 11 million, or is this just for this one contract?
So the 4 total will be the 11 million.
Okay, all right, just want to clarify that. Move approval.
Okay, we have a motion by Mr. Bose. Do I hear a second?
Second.
I think that was a second by Mr. Wynn. Is that correct?
For both of us, so.
Any further questions for Ms. Dent? Hearing none, all in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you. Item I.
The second vendor is CMF Medicon Surgical Services. And as Ms. Dorothy alluded to, this is a combination of the second of the 4 vendors. The total cost over the possible 5-year terms will be $11 million. I'm asking for approval for our second vendor, for our supplies, for our neurosurgery, OMF, dental and trauma supplies, CMF Medicon Surgical.
Okay, you've heard the explanation. Any questions?
Steve, it's Charlie. I'd make a motion to approve.
This is
Okay, we have a motion. Mr. Powell makes a motion to approve. Mr. Zimmerman seconds. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, everyone. We'll move on to item 6. Ms. Walker, any report from council?
The only report I have is the number of contracts under 500,000 for January, and that number was 40.
40. Any questions for Daphne on this item? They're hearing none. We have no items for closed. And there being no further business, the Finance Committee is adjourned. Thank you, everyone.
Wow.
Sir, you did a fantastic job.
2, 1, you're live.
Good afternoon, everybody. It's Thursday, February 25th, 12 o'clock noon. I call to order the JPS Health Network Governance Committee meeting. First up is, has anybody requested to speak to the committee?
Roger, you're clear today.
Great. Being no one, I will ask for approval of our October 22nd meeting minutes.
Move approval.
Got a motion from Dorothy DeBose.
I'll second it, Roger.
All right, Dr. Weber, Mr. Chairman, seconds the motion. I will keep up our normal, if it's okay with Daphne, of asking for any dissenting votes and otherwise have the motion carry. So does anybody not approve of the minutes? Hearing none, I'll declare the minutes approved. I don't have much of a chair report today, other than to spend a few minutes and thanking Mr. Ron Skillins for his services to JPS for the last, was it 4 or 5 years?
About 5.5, yeah.
About 5.5, okay. Well, I guess you and I have been together in this journey for about 3.5, 4 years. And Ron, we really appreciate you and what you've done for the network, what you've done for our compliance and ERM program at JPS. It really has, and I think the board members and everybody will see in the report from Hall Render a very, in my opinion, very glowing report as to what you've been able to accomplish in your tenure here. And I really appreciate that. I really appreciate you taking the time, you know, offline and in other cases, helping me learn more about this, as governance was, or formal governance was something new to me. So I certainly appreciate that, but you're heading to certainly warmer weather and maybe prettier skies out in San Diego. And we're really happy for you for your new position with UCLA Medical Center in San Diego. And I wish you, and I think everybody at JPS wishes you the best of luck in your future endeavors. And thank you very much for your service.
Thank you, Roger. I appreciate that. It's UCSD instead of UCLA.
Sorry.
But no, I've really really grown and learned myself in this journey at JPS and working to build and grow the compliance and risk function. And I will say that the team here with Michelle and Arena and Tim that's here on the call, as well as the rest of the team members, are really outstanding. And I don't believe that there'll be any shortages in terms of after I leave. But it's been a pleasure, absolutely. Thank you so much.
Well, I am. Like I told you before, personally, I'm very happy for you and your next step, but I'm very sad for JPS, for me personally, that this is your last governance meeting. So thank you very much.
Absolutely.
With that, I have not much, and other than to say to our JPS team members, God, you would think that COVID would be enough for a group of medical professionals to deal with, but then you couple that with 5 days or 3 or 4 days of sub-zero weather, and just I didn't get to see much of it, you know, firsthand, but I certainly see the email traffic and the stuff that goes on Facebook. And my hat's off once again to everyone who's a JPS employee, because we've had another instance here in the last week of where each and every one of you have stepped up and continue to deliver very high quality healthcare to all of our patients and to the citizens of Tarrant County. So thank y'all for that. With that, we'll move to item number 5 and consider governance committee reports and updates and discussion. With that, we'll have Ron and an ERM update.
All right. Thank you, Mr. Chair. I just before the meeting, we were just saying we also were unfortunate enough to have some water pipe issues last week from last week's, they call it a polar vortex. And so, you know, I have a parting something to remember before I go to California, for sure.
Like I told you, watch out for that shaky ground.
Yeah, exactly. So today, the first thing I want to say about this meeting here, this February meeting, is that, as the board recalls, we did not have a December meeting, and so there are a few more agenda items in today's meeting than we typically would have on a typical governance committee meeting. And so, if you would bear with us, there's several reports, but we'll get through them as quickly as possible. The first section here is ERM, and change the slide. If we can go to the next slide. Okay, thank you. One of the things I know that is underway, as many of you know, is a strategic planning update. And so one of the things that we've done is to meet with Lauren Poe and her team, as well as the consultants that she's working with on the new JPS strategic planning process. And ERM, Enterprise Risk Management, is meant to be a complement to strategy setting. That's really the definition of what ERM is. Enterprise risks are supposed to be those risks that we are to manage that are relative to our strategy. And so, since we are refreshing our strategy, we're also going to refresh our enterprise risk assessment in alignment with that. So the 10 or 11 areas that we've been working on the last 3 years or so are going to be updated. Some of them may no longer be on the top list. Some of them will likely be. But we wanted to make sure that what we're working on from an enterprise risk standpoint is in alignment with the new strategic direction of JPS. And so I know Arena, who you'll see here in a minute on the next slide, will kind of be heading those efforts from our department, along with coordinating with Lauren and others. As a part of that process, we'll be conducting interviews. Many of you remember the interviews that we've done for enterprise risk management in the past, but we'll do a new set of those based upon the new strategic plan. We'll do a risk survey. We'll get our JPS ambassadors involved to get feedback from them. And then ultimately that will lead to a new list, or risk universe, we call it, of risks that would be selected as our top 10 or so enterprise risks with our new strategic plan. So I did want to just to tee that up and to make the board aware of that. Next slide. And so now I'm going to have Arena to briefly highlight a kind of an industry risk trends report that we thought would be helpful as we move into this process. Arena.
Hi, everyone. Thanks for the opportunity to present. And I just wanted to make sure we highlighted what some of the industry risk trends were for 2021. And this was a survey actually done by NC State University and Protiviti. And they've been doing these surveys for quite a few years. And some of the top trends that were identified, of course, many of them are new due to the pandemic. So the pandemic caused the creation of new government policies, rules, regulations surrounding travel, the shelter-in-place orders, and public health practices. And there were frequent revisions to those policies, and they led to a lot of uncertainty for organizational leaders. So it did end up on the top trend. And it's no surprise that, of course, adoption of digital technologies and managing cyber threats were on the top list as well. A major focus for a lot of organizations was related to identifying the events that may interrupt operations. And cybersecurity is a moving target with all of the new digital technologies that are out there, as well as the increase in the use of mobile devices. And of course, privacy and identity management is looped in as well with digital technologies, because organizations are trying to embrace those new technologies in response to the virtual world that we have with the pandemic and the development of the technologies. And there's also operational challenges to tracking, storing, and protecting that data. The last two trends that are identified on the slide with talent acquisition and retention, executives and board members continue to perceive that experienced and talented workforce is essential to maintaining organizational sustainability. And of course, the concerns remain regarding the resistance to change and the organization's ability to pivot in response to that change. And so it's a pretty in-depth report. It has a comparison of the industry risks for the past 3 years, as well as a longer-term perspective for top risk for the year of 2030. So if anyone would like a copy of the report, we can feel free to forward it. It's a pretty heavy reading, about 187-page report. And the major takeaway from it is that we're going to use some of these trends as well when we start to reset the top risk list here. And we're going to make sure that JPS is future ready when we are transforming the healthcare we deliver to the communities we serve. Are there questions?
Ron, Arena, I don't know who's best to answer this question. So you talked about, Ron, just a few minutes ago, getting with Lauren Poe and the strategic planning. Do they already have these industry risk trends? I mean, is this kind of common knowledge for them? Do they already have this information as they're beginning to work on that strategic plan?
Well, this would be our value add to the process. And so, because typically strategy planning doesn't necessarily involve risk management, and so that's how we would complement the discussion. And so we would work with them, provide them this report and other data, and in the process.
Okay.
Yeah. All right. Thank you, Arena. Appreciate it. And so, Mr. Chair, that ends the ERM report for this meeting. Okay. And if you're okay, we'll move on to the compliance update.
Does anybody have any other questions for Arena regarding industry risk trends?
Nope.
All right, I don't hear anybody, so we'll go to compliance program reports and updates.
Okay.
Thank you, Arena.
All right, we can go to the next slide, please. Thank you. Headlines. So as you all know, I have one slide each meeting on what's happening in the industry, also what's happening at JPS as it relates to compliance. And so I want to start by recognizing the team for doing a great job this past November in Compliance Awareness Month. We did a campaign all month of November, and it was virtual, and so we had to be creative in how we did it. And so we had games and different things that we were pushing out to the workforce to make people aware of how we can serve them, but also impart some information in a fun way that is non-threatening, because sometimes the C word can be threatening to many people. And so we had I think a really good campaign this year. Got a lot of good engagement. We had to be creative in how we typically do this. This is in person, and it's done in conjunction with a lot of other JPS activities, and we walk around the hospital and hand out different types of swag, JPS swag. But we still got it to them, and it was a good campaign. The second point is obviously, as we all have, during the past year, have had to adjust to the new reality of the pandemic and working virtually as well as in person. And so, we've had meetings every day at 9:30 with the team through Microsoft Teams to make sure that everybody's in line with things, everyone's okay. And then as the numbers started to come down, we also then reintegrated back into the office as well. And so, I'm really proud of the team to be able to work through the disruption and still work through our work plan effectively. And then the next one is a headline that's happened here in Texas. There was a CEO in Texas that was over a hospice and home health entity, and it's really an egregious crime in that he was sentenced for $150 million healthcare fraud. And basically, what he was doing that he was telling thousands of patients with long-term incurable diseases that they had less than 6 months to live in order for the patients to enroll in their hospice programs that they were otherwise unqualified for. So they inflated revenue. It was just a terrible situation. So he was sentenced to 15 years in prison as a result of all of that. I picked this one out mainly because it was here in Texas. The next one is for OCR, Office for Civil Rights, which is the agency that oversees the HIPAA privacy. They finally issued their audit report for 2016 and 2017. They just issued it in December of 2020.
Hey, they can't get mad about my tax returns being that.
Right.
It's ridiculous.
Yeah, the government is on its own schedule, and actually, and so even though it was 2016, 2017, the audit report, they audited 166 hospitals and other covered entities, as well as 41 business associates or vendors with covered entities, to see how they are doing and complying with HIPAA. And by and large, what they found was that most organizations met the timeliness requirements when breaches occurred, that there was sufficient information on the website by and large that satisfied the requirement, but that entities failed to provide all the required content in their notice of privacy practices to patients. And some of these are more technical aspects in terms of making sure that they're updated, and failed to provide all the required content for breach notification to individuals and on a consistent basis. And then I won't go into all of them, but one of the pervasive findings across all of the entities that they looked at was that most of the covered entities and business associates failed to implement the HIPAA security rule requirements for risk analysis and risk management, which means that, what the HIPAA security rule requirements are for risk analysis is that have you done a risk analysis of our security posture complying with all the elements of the security rule across the hospital, and based upon that risk analysis, do you have a risk management plan to address the gaps? And so, as you recall, we at JPS did a HIPAA mock audit not too long ago, or about 2 years ago now, and for this very purpose, to address the gaps that we had here at JPS. So even though it is late in getting issued by the government, it is still helpful to understand what the trends are.
Gosh. And by the time my kids graduate college, we'll have the 2022 report. So that'll be great.
Exactly. About 4 or 5 years behind. Yeah. Go ahead.
No, I didn't know if there was anything else to cover.
No. Next slide. Okay, so now I'm going to turn it over to Michelle Atkins. This is the section of the agenda we typically every meeting have as a board refresher training, just a brief training for the board committee. So, Michelle.
Good afternoon. Can y'all hear me okay?
Hi, Michelle.
That's good. So let me talk a little bit about 340B, and again, what is 340B in general? It is an outpatient drug discount program that JPS qualifies for because we are a disproportionate share hospital. So I'd like to cover our universe in general first. We have 74 child sites, and what we mean by that is all of our outpatient clinics, JPS owned, qualify as a child site. And so that's what we mean by those 74. We have 10 retail pharmacies, 8 closed and 2 open door. And what we mean by open door is the 2 open doors are actually open to the public. So the main pharmacy here at 1500 South Main is actually open to the public to take in prescriptions from the general population. The closed doors, of course, are for our child site locations where those other pharmacies are embedded, so the Northeast Clinic, Watauga, Arkansas Lane, and others, so that they are only open to the patient seen at JPS. We do have 163 now contract pharmacies, and for those that don't know what that is, that recently came on board several years ago. We have about 60 Walgreens, about 45 or so Walmart, and 50 some CVS's, where our patients can also have their prescriptions filled at one of these locations, and JPS gets the 340B benefit of that. And of course, we have one central refill location that's in Viola Pitt. The next point that we'd like to make is as it relates to what the HRSA looks at when they do their audit of 340B. So 340B can be a very complicated program, but in essence, they look at your policies and procedures, and then they also look at 3 main areas that I have listed here. And I know that GPO prohibition can be somewhat confusing, and so I felt that it was an opportunity for me to brief the board on that. What you see here is 3 virtual inventory subsets. And so what we have to do is track and manage our inventory in one of these 3 buckets. And so we do have a 340B inventory account, which is typically the most savings. And then we have a GPO account, which is most likely all for inpatient use only. And then we have our WAC account. So it's really important when you're complying with 340B, you have to only for 340B eligible drugs stay in the 340B account. You cannot use a GPO account for your 340B drugs. So that's essentially what the GPO prohibition actually means. So the next slide, please. Drug diversion and duplicate discounts are the other 2 objectives that you typically see for a HRSA audit. And what we mean by drug diversion is, in essence, not segregating and keeping track of these inventory buckets properly. The other 3 things are you're dispensing a drug to an ineligible site. So, for example, one of those child sites, or those 74 child sites, do qualify as an eligible site. The other one would be to an ineligible patient. So if we have not established care for a patient that's not a JPS patient, would not be eligible for 340B. The other one would be a script is written by an ineligible provider. So each month, as the board approves new providers at JPS as they come on board, we take that list. That is, once it's approved, and they are now authorized to prescribe drugs, and so we have to actually disseminate that to our pharmacies so they can have the documentation to support that eligible script. And then all of those things can actually lead to drug diversion if they are not in place. So that's what we mean typically by drug diversion. On the duplicate discounts, essentially what we're saying here is in our mixed use areas, and what we mean by that is typically our emergency department. In our emergency department, we're going to have people, as they transition, they're going to stay outpatient or observation, or they may be inpatient. If at any time during their ED visit they are in outpatient or observation, they qualify for 340B drugs. So as you can imagine, this is the most complicated piece of keeping track of, because we're in a mixed use area where once they have an inpatient order, they are now no longer qualifying for 340B. So in the mixed use area, we file a claim, and what we have to do is we have to essentially put a modifier on that claim so that Medicaid does not also give a rebate to the manufacturer for the same drug that we've just purchased on 340B. So any questions that I can answer with regard to drug diversion, GPO, or duplicate discount?
Well, I'm sure there's tons of questions and maybe just to clear up some confusion. But can you talk to us? I know we had the 340B audit, and if I remember, it wasn't altogether a terrible audit. What steps we took to end any of those diversion processes, and then has there been a follow-up 340B audit to make sure that we're still in compliance?
Yes, sir. We will be discussing that in closed session today.
Okay, all right.
And we absolutely have had controls in place in all of these areas since the establishment of the program.
Great. Any other questions?
Nope.
All right. Well, thank you, Michelle. Hey, Ron, I've got a question. Arena's presentation for the industry risk trends, will that report be posted on the portal, or can we get that?
Yeah, absolutely. I don't believe that was part of the portal information, but I will provide it to all the board members.
Okay, yeah, that would be great.
Okay.
All right, we'll move to item C, policies for approval. I had a request from Ms. DeBose to table item 4, and without objection, we'll do that. That's IA 9000 internal audit charter. I think that there's some interaction that needs to happen with human resources, and Dorothy asked for a little bit more time on that one. So without objection, we'll do that, and we will cover items 1, 2, 3, and 5.
Okay. All right. Next slide, please. And what I'll do is I'll go through a high level for each of the 4 policies, and then take questions. And these slides are just high level to give you an overview. As is always the case, these policies and associated procedures for reference purposes are in the board portal for your information. The first one is LD 1000, orientation for board members, senior management, leaders, and organized medical staff. As you recall, we had a prior meeting to discuss this one at length in terms of responsibilities for initial orientation, ongoing education, and so forth. And so it reflects those. Well, actually, I take that back. That was standard operating procedures. I'll take that back. That was standard. Yeah, that was SOPs. This LD 1000 is just more of a policy statement that we've always had that provides just our direction that we're going to do that information. The SOPs is where it actually implements that. So there's no changes to this policy statement on LD 1000. LD 8000 compliance.
Do we need to take these individually, Ron? I think we do. If Daphne's here. I think we do. I'll tell you what. Does anyone have any questions on LD 1000?
I do, Roger. On that
yes,
one,
ma'am.
when I read it, in part of what your general information, could we add strategic plan to that list under the board, under general information, what we will cover? We talk about mission, vision, goals. I would just think strategic plan would be added somewhere. Okay, that's all I have.
Okay.
Yeah, I don't have any particular problem specifically mentioning that. Would you like to make that in a motion, Ms. Dorothy?
Yes, I would like to see strategic plan as added as one of the items that will be covered through orientation.
Okay. So we have a motion to approve LD 1000 with strategic planning as part of the education materials. Do I have a second?
Zim seconds.
Zim with a second. Any opposition to this passage? All right, the motion carries with changes. Thank you, Dorothy. It's a good point.
All right, thank you. LD 8000, compliance with Medicare Two-Midnight Rule. This is a new policy. It really kind of reinforces, as it says there on the slide, our commitment in writing to comply with the Two-Midnight benchmark. As you know, we've done some audit work in this area relatively recently and continue to do so. And this is an area that has always been a challenge for most providers. And so we thought, as a part of the the process to state our intention to comply with the Two-Midnight benchmark, that would be a good idea to have this as a formal policy as well. What's stated at the bottom of the slide is just some OIG guidance that came out in November of last year that that they intend, if they were to do a review, to review policies and procedures for enforcing Two-Midnight Rule compliance at the administrative level. So this would also help us to, if ever reviewed by OIG, hopefully not, to comply with that as well.
Anybody have any questions on this new policy, LD 8000?
Compliance coding policy. This also is a new policy. As it states in our summary, this reinforces our commitment to ethical, accurate, and consistent coding and documentation. This came about from the compliance program assessment report that's in your portal. One of the recommendations that came out of that review was to have a formal compliance coding policy, and so this is a part of that action plan.
All right. Is there a motion to approve COM 8600?
Move to approve.
Move approval by Zim. Is there a second?
Second.
By DT. All right. Is there anyone that opposes the approval of COM 8600? All right, the motion passes.
All right, thank you. And then the last one is LD 9000, internal audit scope and independence. As it states in our summary, this establishes internal audit responsibilities and independence from operational activities. This was an existing policy, just came up because it had met the 3-year mark for a review, no substantive changes.
All right, thank you. Is there a motion to approve LD 9000?
Move to approve.
That's Mr. Zim. Second? Was that you, Dorothy? Is there a second on the motion to approve LD 9000? Oh, okay. All right. Thank you, Dr. Weather. I got a lot of chatter I can't hear. All right. We've got a motion and a second. Is there anyone who does not approve of LD 9000? All right. The motion passes.
All right. Thank you. I believe, Mr. Chair, that is all we have for open session.
Okay, great. Thank you, Ron. David, if you can get us off of the web, and let's start back in closed session. Give everybody a 3 or 4 minute break. We'll try to start back at about 12:35, 12:36.
All right. Thanks, Roger. We're on it right now.
Okay, thanks.
Thanks.
Thank you. We are re-adjourning the regular session of the Governance Committee meeting at 2:01 p.m. With no further business on our agenda. I declare this meeting adjourned. Thank you all.